Professor sir, and my dear students, I welcome you all to another session of RISA TNP online activities today. Today we have an interesting case discussion on liver disease and anesthesia. Over to Dr. Balasundaram and Professor and other students. Thank you, sir.
I'm sorry, there is a correction here. Yesterday, Dr. Balasundaram asked me whether I will give a case scenario for discussion or whether he has to select a regular case. And I already messaged him that it is not going to be a discussion like that. Did you not communicate it to Dr. Kamachi Balasundaram?
Sir, communicated, sir. Sir, kita sollitam, sir.
Okay.
Interactive session.
It is always interactive only. I am not a fan of didactic lectures at all. So I wanted to make it a little bit different from the regular discussions to see how it will be effective and receptive by you people. How many of you know the book Yavo and Artusio, Problem-Oriented Patient Management in Anesthesiology? How many of you follow that book? Or how many of you have seen that book?
I have heard about that book, sir, but
You have heard about it, you have not seen.
no.
Okay. Jay Bharati, have you heard about that book? So Jay
No,
Bharati,
sir. No, sir. Yes, sir.
have you heard
No,
about
sir.
the book
No, sir,
called
I have.
Yao?
I have heard about it, sir, but not
You have not,
studied that book. Yes, sir.
So that's a very interesting book which discusses all the topics on a question-answer basis. So it suddenly struck me, why not we have a discussion like that? And instead of asking you to the same old way of presenting a case and then interrupting in between, or having a discussion at the end and then going on to describe about all these things. I thought we'll have a different approach to this topic, liver and anesthesia, which is a very important topic from both area exam point of view and in clinical examination also. 5 hours also, they keep these cases for you. So the first question I would like to ask you is, what are all the pathologies of the liver with which we as anesthesiologists are involved in, or we should be interested in and have a good knowledge about those diseases? Can you name a few conditions which affect the liver with which we are also involved as anesthesiologists in some form of treatment? It may be intensive care treatment, it may be surgical anesthesia, or it may be post-op care. So can you name a few conditions which affect the liver?
Acute liver failure, cirrhosis of the liver,
Non-alcoholic fatty liver diseases,
Okay.
hepatitis B, hepatitis C.
Supposing a patient has a routine ultrasound abdomen done for a master health checkup, and the report says he has steatohepatitis or a fatty liver. Will you be involved in that treatment, or will you be involved in the management of that patient?
Routinely, no treatment, sir. We advise exercise and dietary changes, sir. If there is a changes in the
They
liver
will
function,
be seen mostly by the physician or the gastroenterologist, right? We don't have a immediate, unless you also practice like a general physician and you get a patient and you then see a fatty liver, then you advise the patient accordingly with regard to the dietary changes and how to manage that. What will be the long-term effect of a fatty liver if it is neglected and not taken care of? What will be the long-term effect?
that non-alcoholic fatty steatosis causes long-term cirrhosis and portal hypertension.
It can also lead to cirrhosis of the liver. So one of the causes for cirrhosis is also progressive fatty liver or non-alcoholic steatohepatitis, NASH as it is called. Okay. So that is all the involvement that we have. But more than that, what are all the conditions, surgical conditions where you will be involved to give anesthesia in the pathology affecting the liver, or you will be attending to the patient as an intensivist in intensive care unit, or you should be very, very careful in avoiding getting a infection from the patient. So what are these three areas you should be knowing as an anesthesiologist? The topic today is liver and anesthesiologist. So I am just trying to find out how many of you have thought about this topic and have an idea about how to discuss and deal with this topic. The first part is, what is the surgical involvement as an anesthesiologist you will have in dealing with the patient? What pathological conditions of the liver where you will be giving anesthesia to the patient? Second thing, what pathological condition where you may be treating the patient as an intensivist if you are planning to become a full-time intensivist after your qualification. Third, what are the protective strategies you should be following to avoid getting iatrogenic infection from the patient and suffering yourself?
So
Uh,
coming
my
to
question clear?
yes, sir.
Yeah.
Coming to exposure part, emergencies will be acute cholelithiasis, obstructive jaundice, and everything, sir,
Hmm.
which involves a
Exposure to
surgical
what? No, the first
critical.
part is anesthesia management. First part is anesthesia management. Second part is ICU management. Third part is your self-protection against contracting a liver pathology from the patient you are treating.
Sir,
These are
acute
the
hepatitis, liver failure, like drug toxicity, sir, drug intoxication, sir. Metastatic
okay, that is
cancer,
for
sir.
what? That
Sir,
is for what? This pathologies you will be treating as in what capacity? As an theater anesthetist or an intensive care specialist?
sir, drug
Acute
intoxication as
hepatitis,
an
drug.
intensive care, sir.
You will be treating them in intensive care. Very good. What about anesthesia? Which are all the cases with a liver pathology you will be asked to give anesthesia?
Sir, biliary
Just name
calculus,
the
sir.
pathologist. Huh?
Biliary calculus, sir. CA gallbladder, sir. And cholestasis, sir. Cholelithiasis. And
Hmm. Okay. What is the more
pancreatic.
common pathology which we are asked in the exam?
Obstructive
Commonly,
jaundice.
obstructive jaundice is one case. Very good. Obstructive jaundice patient coming for some surgery, either to correct the obstructive jaundice or incidental surgery with an obstructive jaundice. This is one pathology with which we will be facing to give anesthesia. Any other pathology which is more common?
Ascites.
Ascites is only a symptom or a
Hepatocellular jaundice, sir.
none of you are thinking about cirrhosis and decompensated liver disease.
Yes, sir.
Okay, the second
Yes, sir.
important topic with liver is, in fact, the first topic which will be commonly kept in the examination is patient with a cirrhosis liver. Even though we started off with fatty liver, which ultimately progresses on to cirrhosis liver, what is the most common type of cirrhosis we come across nowadays? With the government lenient in opening a lot of TASMAC shops,
Alcoholic liver.
Alcoholic cirrhosis.
that is the most common, alcoholic cirrhosis of the liver. That is a very, 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 very common complication of chronic alcohol abuse, and that cases will be plenty, and it may be kept in the examination. Okay, so three important pathologies with which we will be facing as anesthesiologists. One is patient with cirrhosis liver coming for surgery. Second is patient with obstructive jaundice coming for surgery. Third is a patient with malignancy of the liver coming for surgery. Okay, these are the three categories of liver pathologies which we will be dealing with in the management. And of course, hepatitis, if you are going to be a full-time intensivist, you may be facing a acute hepatitis patient, which may be of viral origin, or as Bala said, it may be of toxicity due to drug overdosage or acute toxins due to various causes. Okay. So with this background, today's class discussion will be, there will be a question and you have to enumerate the answers for that. So that is the pattern that is I'm going to show you. So let me share my screen. You able to see that?
Yes, sir.
So even though the title of the slide shows liver and anesthesia, mainly DCLD and cirrhosis. I hope all of you know the expansion for DCLD. What is DCLD?
Decompensated liver disease.
Liver disease.
Decompensated liver diseases. Okay. So this is the first pathology with which we will be dealing with. So the first question for that is, what are the important history you have to elicit or to be elicited from the patient who is suffering from either DCLD or cirrhosis of the liver? What are the important history? Because if you are given a patient, you are going to ask the patient, what is your complaint, why you have come to hospital, what are all your
History of
problems?
jaundice. History of jaundice, sir.
In DCLD and cirrhosis, first question you want to ask is, what will be the patient's description of his problem? Will he say, I am suffering from jaundice or yellow coloration of my...
Yellow discoloration of the skin and
Complaints of breathlessness
Abdomen.
and edema.
Complaints of breathlessness, complaints
history
of
of abdominal
jaundice,
distension, sir.
abdominal distension. Okay, then. What is the most starting point of the disease? Which is the most important starting point, or how does the patient start to feel that his body is not all right?
Loss of
Easy
appetite.
Patient may be having history of chronic alcohol consumption, because this is the most commonest problem with which the patient develops this problem. Once this becomes leads to the DCLD or cirrhosis. Important history you should ask the patient is, what is, have they ever had a blood transfusion or IV substance abuse? These are all the history that you want to. Patient may be having a lot of complaints that will come in the next slide, but you have to ask the patient, are you a chronic alcoholic? Have you ever had a blood transfusion? Do you have any IV substance abuse, or have you ever had a tattooing? Why tattooing is important?
Hepatitis
The needle may be
transmission.
used for the same patient by the tattooing person. So it may carry hepatitis virus, and that could have caused this problem. Now, after I have given you these two important history that you want to elicit from the patient, can you enumerate further what other history you want to elicit from the patient? The third is high-risk sexual behavior. That means he must have contracted what problem? HIV.
HIV.
Then travel history. The patient has gone to an area where the hepatitis is endemic. Then drug intake, whether the patient has been taking any drug which is prescribed or over the counter. What prescribed drugs can cause this problem of liver involvement?
Paracetamol toxicity.
Paracetamol toxicity, that is overdose. Very good.
Toxic dose.
Any
Yes.
other treatment-based drug intake given for a chronic condition, inoperable conditions?
TB drugs.
TB drugs or chemotherapeutic agents. Okay, those, even though they are given to treat the patient, they can cause this problem. Okay, and whether the patient has any family history of liver disease or obesity and lack of proper nutrition. And so these are the 7 history points that you should elicit from the patient. Whether the patient had a chronic alcohol consumption, whether he had blood transfusion or IV substance abuse, high risk sexual behavior, travel history, drug intake, family history, and lack of proper nutrition. So you should not forget to elicit all this history if a patient who looks like a cirrhotic patient given to you in the practical or viva examination. Now, what will be the common complaints patient will tell you if he has got a cirrhosis or a liver disease?
Yellowish discoloration of eyes
with
and
jaundice.
urine, sir.
That
Yes.
is the most common presentation.
Fatigue,
Jaundice,
itching,
abdominal
Ah.
distension.
Malaise, fatigue, and loss of appetite. Okay, this will be the first and foremost problem or common complaint. Then patient may say that he has a progressive distension of abdomen, which you all mentioned. Can you further elaborate? Other than these two,
Jaundice, sir.
sometimes
Itching,
they may have jaundice.
itching over the abdomen.
Itching, pruritus,
Pruritus.
very good. Pruritus, very good.
Headache,
Okay.
sir. Headache, sir.
Headache. Why
Headache.
headache? Why headache?
Due to the
Huh?
due to the jaundice, sir.
Jaundice, headache. Anything else? Just think of vomiting of blood and easy bruising. Can that be the presentation?
Yes, sir.
Gastritis.
Yes, sir.
Esophageal varices and
Portal
easy
hepatitis.
coagulation problem. So think of each system, then you will know what complaints will be made by the patient.
Drowsiness, sir.
Drowsiness, extreme cases. Okay. Edema legs, tremors in the hand. The cirrhosis always produces what type of appearance in the patient? Have you heard of the term poverty above and prosperity below?
Yes, sir.
Yes, sir.
So if you think of that, patient will be able to tell you all that. So testicular atrophy or gynecomastia in male, and then changes in the color of the palm, pruritus or jaundice. These are all coming under the appearance category. What is the change in the color of the palm called? Palm. The clue is in the palm itself. Palmar
erythema.
Palmar erythema. Patient's hands will look red, even if he is a dark person, because of the vascularity, increase in vascularity, palm may look reddish. So it is called palmar erythema. And patient may have severe pruritus, and we may have jaundice occasionally. And there may be tortuous swelling around the umbilicus. What do you call that?
Caput medusae.
Caput medusae. Very good. So these are the common complaints. Malaise, fatigue, and loss of appetite will be the beginning stage of the disease. Then there will be progressive distension of the abdomen, going on to ascites, full-blown ascites. Occasionally, they may come first time with itself with a vomiting of blood, and they may have edema legs and tremors in the hand. If a male patient, they may have complaint of testicular atrophy, changes in this color of the palm, and tortuous swellings around the umbilicus. And lastly, relatives also may say this patient has been having an alcohol abuse habit. So that may be the complaint, not by the patient himself, because no alcoholic will admit that he is indulging in that activity. So it may be the complaint by the family members, especially the wives will come and say he has taken to alcohol and drinks right from the morning to night. Okay? So these are the complaints or common reportings that the patient will make. So actually this slide, if it has come as the first one, that would have been better. So once you know the patient complaints, you elicit all the history shown in the previous slide. Now this picture, if you remember, will be easy to enumerate all the symptoms of the liver cirrhosis. You can see general malaise, fatigue, anorexia, weight loss, feeling of enlarged abdomen, swollen abdomen, legs, nosebleed or bleeding from lower limbs, jaundice and leaks, hand tremors. These are all the symptoms of liver disease. And physical findings you will find will be skin pigmentation, xanthoma, spider angioma, palmar erythema, finger clubbing, and caput medusae, gynecomastia and fever, and hepatoselloma, halitosis, and all these things will be the various physical findings that you will face. So we remember this. Now coming to this particular physical finding, clubbing. This may be the important discussion in the examination. The examiner may ask you to define clubbing. What is clubbing?
Hypertrophy of nail bed.
Bulbous enlargement
Bulbous enlargement,
of the nail
hypertrophy.
bed.
Who can say the correct definition of clubbing? It should have been taught in your UG days, in the first posting in your medicine. When you see a patient with clubbing, the medicine teachers should have taught
Bulbous
you
enlargement of the ends of one or more fingers or toes, sir. It's a proliferation and edema of the connective tissue, sir. Between the skin and the nail plates, sir.
The abolition of the angle between the nail and the nail bed. That is
Yes.
the correct definition of clubbing. Abolition of the angle formed by the nail and the nail bed is the correct definition. Okay. The bulbous development is all one variety or one stage of clubbing, one type of clubbing. Okay. It is not the definition of clubbing. So if the examiner asks you what is the definition of clubbing, the answer should be it is the obliteration or abolition of the angle between the nail and the nail bed. What is the normal angle? And what is that angle called? Is there any name
Lowy
for
bond
that?
angle.
Lowy Bond's angle. Very good. Okay. So, and it should be 140 degrees. It is an obtuse angle. And when it gets obliterated, it becomes, there is no angle at all. It becomes bulbous or it becomes rounded. So there is no line that are happening at all. Okay. And what are the causes of clubbing? Clinical conditions or pathologies which cause clubbing. How do you classify?
Bronchiectasis and CA lungs, sir.
Okay. How do you
Cyanotic
classify?
heart diseases.
Clubbing
DCLD.
happens due to variety of pathologies in various systems. It is not unique to one particular system alone. Okay, it can be due to respiratory causes, it can be due to cardiovascular system pathology, or it can be due to hepatic pathology. Okay, so clubbing is, and it may be congenital also without any pathology. So these are the four varieties: congenital clubbing, clubbing due to cardiovascular pathologies, clubbing due to respiratory pathologies, and clubbing due to gastrointestinal or hepatic pathology. Even Crohn's disease can produce clubbing. Ulcerative colitis, all these things can produce clubbing. Okay. And the mechanism of clubbing, what are the theories which are described to say why clubbing happens?
Platelet
Clubbing
growth
happens
factor.
because of the,
theory regarding platelet growth factor.
Very good. This is platelet growth factor. Then hypoxemia. See, whenever there is a hypoxemia, what happens in respiratory pathology? The mechanism is described due to hypoxemia. There is more stasis of blood in the capillaries at the peripheral most part of the body to give more oxygen to the tissues. This results in more nutrition also passing on to the tissues, which start to grow and obliterate that angle. Okay, so these are the various theories that are proposed, and there has been some genetic theory also caused for this, for the presence of congenital clubbing. Okay, so the clubbing, the last question they may ask you is, what are all the various grades of clubbing? In that only you have to describe the bulbous thing like drumstick or the parrot beak appearance, then the distal osteoarthropathy. All these things are increasing grades of clubbing, which result in the various formation or shapes of the fingers and the wrist. Okay, so this question you have to expect if your presentation has clubbing when you examine the patient. Okay, so this is a very important thing which you all have to read and remember in your. Now, what are the types or causes of liver cirrhosis? Is it only fatty liver or alcohol common causes, or are there any other causes which also result in cirrhosis of the liver?
Sir, hepatitis B and C virus, Wilson
Okay.
disease,
Post-hepatic cirrhosis, very good. Then the
hemochromatosis,
commonest cause
Wilson
is
disease,
alcohol or nutrition in our country. Next comes
alcohol,
the,
sir.
so first and foremost is alcoholic cirrhosis, then nutritional cirrhosis for want of proper nutrition, then hepatitis induced cirrhosis. Okay, which type of hepatitis infection can lead to cirrhosis? Can all hepatitis?
Hepatitis C
C and
virus,
B, sir.
C
leads
virus.
to carcinoma of the liver. Okay, B is the most common infection which can lead to cirrhosis in the long term. Okay, so the types can be alcoholic cirrhosis, post-necrotic cirrhosis, primary and secondary biliary cirrhosis, non-alcoholic steatohepatitis, hemochromatosis, and Wilson's disease, and alpha-1 antitrypsin deficiency. So these are all the various types or causes of liver cirrhosis. Now, how do you classify the phases of cirrhosis? Is there any classification or distinction of cirrhosis?
Sir, pre-hepatic, hepatic, and post-hepatic.
The
Sir.
clue is here in this acronym. The clue for this question, the answer for this question is in this PCLD. You said it is decompensated liver disease. So what should be the other one?
Compensated.
Compensated liver
It
disease.
should be compensated liver disease. So phases of cirrhosis are, for a long time, liver gets compensated. How liver is able to withstand the insult? Supposing somebody drinks about 1 liter of alcohol every day, from morning to night, for 5 years, 10 years, and the liver gets so much inflamed, but still it does not fail and become decompensated for a long time. How is it possible?
Initially, hypertrophy.
Liver has got a enormous power of regeneration. Okay, if the person stops drinking even for 1 or 2 days, whatever damage has been done by the chronic use of alcohol will be compensated by the formation of new hepatocytes. So liver has got an enormous power of regeneration or fighting to come back to its original state. Why? How is that possible again? That is the next question. What gives the liver this character of coming back to its original shape or regeneration?
By its productive mechanism, sir.
What productive mechanism? It will be more clear.
Hepatic arterial buffer response and
These
metabolic.
are flex up like no. That is not the answer.
Okay.
Now I will give you another clue to find out this answer. Whenever your blood cells, the RBCs, WBCs decrease in number, how are they reproduced and how are they replaced in your blood? Where are they reproduced from?
Reticuloendothelial.
Stem cells.
Reticuloendothelial.
You have stem cells from the bone marrow, isn't it? So what do you call those stem cells which produce RBCs, WBCs, the various categories of all these cells?
Pluripotent stem cells, sir.
Pluripotent. But what stem cell produces the liver cells or hepatocytes? Then what is the opposite of pluripotent? Unipotent. Okay. So the liver regenerates because the stem cells which are contributing to the regeneration of hepatocytes are unipotent in nature. That means only hepatocytes will be produced from that stem cells. Whereas in the blood cells, one stem cell gives rise to macrophages, one cell gives to platelet, the same cell gives rise to RBC, same cell gives to WBC. So the capacity to regenerate is very much limited. Whereas in the liver, because it is a unipotent stem cell, that is why if you do a liver transplant in a child, from taking a part of the liver from the adult, as the child grows, what will happen to that liver? It will be remaining the same or it will become bigger?
It will become bigger.
It will become bigger in 72 to 4 days, 3 to 4 days time. That much of capacity to grow again will be there in the liver. That is because it is derived from a powerful unipotent stem cell. Okay, so that is why liver is able to compensate for any insults for a very long number of time until it cannot reproduce any more hepatocytes, then it becomes decompensated. Okay, so the phases of cirrhosis are compensated and decompensated. Now the next question they may ask you in the exam, enumerate the changes in the various systems due to chronic liver disease or cirrhosis. Now what I have written there as chief ranges is a mnemonic to remember the various systems that are affected by cirrhosis or DCLD. I always remember the points by remembering the mnemonics, but that should not confuse you to find out which mnemonic to use for which condition. So if you remember this mnemonic, you will be able to. Can you just decipher what this mnemonics may be indicating? See, what does it stand for?
Cardiomyopathies.
Cardiovascular system changes. Okay. The question is, what are all the various systems that are involved? So the C stands for cardiovascular system changes. Can you enumerate what are the cardiovascular system changes that will be seen in DCLD or cirrhotic patients?
Systemic hypertension will be there, sir.
Systemic hypertension.
Yes, sir.
No.
So decrease in the systemic vascular resistance and
Very good. Systemic vascular resistance. That means the diastolic blood pressure will be low or high. Low.
Yes,
Systolic
low.
will be same. So
Yes,
what
sir.
will happen to the pulse pressure?
Will be bounding, increased.
Wide. It will become wider.
Wide.
So patient will have what is called a hyperdynamic circulation. Okay. So diastolic pressure becomes low because of decrease in HVR. So pulse pressure becomes wide. So patient will have a hyperdynamic circulation. Any other changes? What will happen to the heart rate?
Increased heart rate, sir.
Increased heart rate. Hyperdynamic circulation, cardiac output increase. Will the heart rate increase or
Decreases.
more of bilirubin? Bilirubin, what is the effect of bilirubin on the heart rate?
Blunted contractility causes myocardial depression,
Heart
sir.
rate. Please listen to the question and answer. What happened to the heart rate if bilirubin increases?
Decreases.
Decreases. Why? Because of its bilirubin's action on which part of the heart?
SA node, sir.
SA node.
SA
Deposition
node.
of
It will suppress the SA node. Okay. Bradycardia is a very pathognomonic feature of jaundice. Patients, whenever they have increased bilirubin, it will affect the SA node and cause a decrease in the heart rate. A patient who is deeply jaundiced, instead of having a heart rate of less than 60, he has got a heart rate of 110. What should it tell you? What should you think of?
Patient is in failures.
Failure, fantastic. He is a decompensated heart. So normal healthy heart should exhibit only bradycardia. On the contrary, a deeply jaundiced patient has a tachycardia. It indicates underlying heart failure or a decompensation of the heart function. Okay, this is a very important point given long back in the first edition of Miller itself. The tachycardia in a jaundiced patient always indicates a very severe degree of cardiac failure. Okay, so CVS decreases in SVR, increase in cardiac output, and hyperdynamic circulation will be there. Okay, what do you think the second H stands for in the mnemonic?
Hematology, sir.
Hematology, fantastic. So, what are the changes in hematology? Can be anemia,
Anemia,
or coagulopathy.
coagulopathy.
Okay, what is I stand for?
Immune.
Immune responses. So patients usually have decreased immunity, which may result in what is SBP?
Spontaneous
bacterial
bacterial
peritonitis.
peritonitis.
Spontaneous bacterial peritonitis, or you can go for sepsis. Okay, what does the E stand for?
Encephalopathies.
Encephalopathy or okay, encephalopathy also. Actually, E I think missed. F stands for fluid, which can be
Fluids.
hypo or hyper volume status. What does the R stand for?
Respiratory systems.
Respiratory and renal involvement. It can be in the form of what is HPS?
Hepatopulmonary syndrome, sir.
Hepatopulmonary syndrome. POPH?
Photopulmonary hypertension.
Photopulmonary hypertension, orthodeoxia, and pulmonary hypertension. These are the four things that you have to remember with regard to respiratory system. Whereas for renal, what is HRS?
Hepatorenal syndrome.
Hepatorenal syndrome. Okay, so these are the things that you have to remember for R. And A, the next A stands for 2, acid base and albumin. Okay, so respiratory and metabolic alkalosis will be there and albumin will be decreased. What other importance this albumin has got? Estimation of albumin. How is it important in liver patients? Patients with liver derangement. Does it have any prognostic value?
So, MEL score.
Child-Pugh score, sir.
It is one of the important prognostic indicators. Okay, so albumin is taken for and assessing the risk involved and the assessment of morbidity and mortality. So it is one of the prognostic indicators, albumin, which gets decreased because hepatic cells are not able to synthesize the albumin in a normal way. And what does that N stand for? We saw the various types of cirrhosis which can be caused by alcoholism, nutrition. Okay, so N for nutrition, lack of nutrition due to anorexia and impaired absorption. Then G stands for
Gastrointestinal.
GA, gastrointestinal and glucose metabolism. So in the gastrointestinal system, patient may have esophageal varices, nausea, jaundice, or we may have spells of hypoglycemia. Why patient goes for hypoglycemia if they have a liver disorder?
Gluconeogenesis will be affected.
Is it more gluconeogenesis or more commonly? Whenever your body, you don't eat, even in a normal patient, if they don't eat and starve for a long time, which one will come to help to maintain the blood glucose level?
Glycogen, sir.
Looks like
Glycogenolysis.
glycogenolysis. The glycogen store will be the first one to replace the lack of glucose. Neoglucogenesis comes on later on. Okay, so the
Yes.
glycogen stores will be lost if the patient develops liver failure. The glycogen store, which is the immediate storehouse. So you have a storage of glucose. What is the difference between glucose and glycogen? These are all basic biochemistry which have not been taught to us, including me.
Glycogen is a branched carbohydrate.
Many carbohydrate molecules clubbed together is called a glycogen. Okay, so
Yes.
whenever you need glucose, glucose is a single molecule. If you put together 10, 20, 30 glucose molecules together, it becomes glycogen. So you have to cleave the glycogen and release the glucose molecule to get back to your utilizable form of glucose. Okay, so glycogen storage becomes less, and of course neoglycogenesis, that is making glucose from other substrates like amino acids and fat, all these things also is affected, but that is only the next step. So glycogen storage is very important. Even when you are doing a dharna and fasting, say fast unto death, first your glycogen storages will be exhausted. Then only your neoglucogenesis will try to help you for some time. Then only you will become totally hypoglycemic. So hypoglycemia is mainly due to lack of glycogen storage. Then what is the E stand for?
Encephalopathy.
Encephalopathy and electrolytes. Okay, encephalopathy, electrolytes. So actually, this first E should have been there for electrolytes. The patients may have, what type of electrolyte imbalance may have these patients? I should correct this slide. It's been there for quite some time. So you can sodium
Hyponatremia.
hyponatremia because of fluid high volume overload. If it is there, he will, because fluid, it can become hypo or hyper. So depending on that, he may have hypo or hypernatremia. And of course, encephalopathy. What is the encephalopathy due to? What is the pathology?
Ammonia, sir.
Ammonia deposition. Why ammonia gets deposited?
The free ammonia can cause the blood-brain barrier and
Okay, but why ammonia should accumulate in liver failure?
Urea cycle is affected, sir.
Ornithine or urea cycle. Ammonia cannot be excreted in the urine directly. So it has to be converted to urea with the help of, by adding what to ammonia?
Ornithine.
Ornithine is the name of the person who developed this.
hydrogen and carbon dioxide.
Carbon dioxide, not hydrogen. Ammonia
Oh.
plus carbon dioxide produces urea. Remember that simple step. Okay.
Yes.
So carbon dioxide is available in the body, and ammonia that is done in the liver. Then urea is water soluble, it will be excreted. So because liver is not able to do this conversion of ammonia into urea, ammonia starts accumulating, and that ammonia will affect the brain cells and produce encephalopathy. Okay. And lastly, the skin changes, pruritus and petechial hemorrhages all will be happening because of the coagulation in the skin. And why pruritus?
Because of increased bilirubin,
Bile salts. Bile
bile
salts.
salts.
Okay, bilirubin is not because it's the bile salts. What are the bile salts that are produced in the body? What is the name?
Quinodeoxycholic acid and
Sodium taurocolate and glycocolate. Okay, sodium taurocolate and glycocolate are the bile salts, and they have a irritating nature. So that causes irritation. Sometimes the patient may come mainly because of pruritus, and you have to check your bilirubin will be high, and you may be having occult jaundice at the time. It may not be clinically detectable. So sometimes patient may seek treatment for pruritus also. So how do you manage that pruritus? What are the things that you can do to clear the pruritus? Patient complaining of severe pruritus, what is the options? What are the treatment options that you have? Any
can do
idea?
bile drainage, sir.
Bile drainage. You have to give them some drugs to treat them, no?
UD sir, tablet UD
Yes, sir.
will give, sir.
UD leave is given for pregnant patients. Okay? To correct that.
Yes.
What is UD leave?
Uro deoxycholic acid tablet, sir.
Urodeoxycholic acid. Okay. But how does it work? Does it restore the normal liver activity?
No, sir.
Sometimes you have to, pruritus will be found in this patient. The mechanism of pruritus can be central origin, can be because of increase in central opioidergic tone, or it can be because of peripheral origin, accumulation of bile acids and salts due to failure of liver to treat that and stimulate the histamine and serotonin and endogenous opioids. So the treatment sometimes can be tablet naloxone or cholecystramine, or even rifampicin has been used for treating this condition. So the drug treatment for pruritus is naloxone because of the theory that it increases the central opioidergic tone. You use naloxone to correct that. And you can use cholecystramine to sequestrate the bile salts, and you can use sometimes rifampicin also. So these are the treatment options for the pruritus and the mechanism. This is asked sometimes in the examination. In the viva, they will ask you what are the mechanisms of pruritus. Remember, it can be of central origin or peripheral origin. And central origin because increase in opioid tone, opioidergic tone, and peripheral origin because of accumulation of bile salts and acids. Okay. Now describe the stages in the development of decompensated liver disease or cirrhosis. What are all the various stages? How do they progress from normal liver to completely cirrhotic liver? How do they progress? What are all the in-between stages? This knowledge is important because we can revert or arrest the progression to cirrhosis or decompensated state if you know what are all the stages through which the liver gets damaged. Any idea? So this picture will tell you, see, you have a normal liver. Then you have steatosis, that is fat starts accumulating. Once the fat starts accumulating in the liver, the fat irritates the liver and produces inflammation in the liver. We call it as steatohepatitis. And any inflammation heals by fibrosis, by the production of the collagen. And once the fibrosis occurs, then it starts shrinking, becomes nodular. The smooth surface is lost and it becomes like a irregular nodular shape, which is called cirrhosis. And if the cirrhosis is allowed to continue, ultimately it may turn into hepatocellular carcinoma. So normal liver, steatosis, steatohepatitis, fibrosis, cirrhosis, and so is there any investigation with which we can find out these stages, which is available in the
Fibroscan, sir.
Fibroscan of the
Fibroscan.
liver. Very good. So that will tell you the grades. So nowadays, all the gastroenterologists, if the patient goes with symptoms of any liver pathology, they advise them to go through what is called the fibroscan. That scan will be able to tell you the consistency and the change in the structure of the liver, which will be telling you the stage of the liver involvement. Now, alcoholic cirrhosis or alcoholic affection of the liver is the most common thing, as we saw in the discussion. So the examiners may ask you, how is alcohol metabolized in the body? Whenever somebody takes alcohol, how is the alcohol metabolized in the body? This is a very common question that you have to expect in the viva examination. Nobody is taking alcohol in the class group? Any idea? Yes or no? If you don't know the
No.
answer, say no, sir.
No,
then
sir.
I'll
No,
say
sir.
no answer.
No,
Okay.
sir.
So the answer is this. There are three pathways for metabolism of alcohol in the body. One is called the major pathway. This is happening in the hepatocytes. Alcohol is metabolized in our liver cells or hepatocytes, and the major pathway happens in the cytoplasm of each and every hepatocyte. And in the cytosol, the ethanol is converted to what is called acetaldehyde by alcohol dehydrogenase. This ADH stands for not antidiuretic hormone, but this is alcohol dehydrogenase enzyme. This is the enzyme which converts ethanol into acetaldehyde. This happens in the cytoplasm of hepatocytes. This is the major pathway. Then hepatocytes have the organelles called peroxisomes, where also it is broken down to what is hydrogen peroxide, then to water. This is an accessory pathway. And an inducible pathway, depending upon the amount of alcohol taken, the load that the patient poses to the hepatocyte. This is an inducible pathway which will come and act temporarily. Where else you have an inducible enzyme production in the body? The clue is in the vascular system. Where do you get an inducible enzyme production? Endothelium produces one enzyme constantly, and another enzyme can be induced. What is that enzyme called, or the chemical? Have you not heard of nitric oxide? E-nitric oxide, ENO and INO. Inducible nitric oxide and endothelial nitric oxide. Okay. So similar to that, there is a major inducible pathway in the endoplasmic reticulum of the hepatocytes, which also acts through the cytochrome P2E1 enzyme to convert this NADPH into NADP. So all these reactions are taking place in the cytoplasm or cytosol of the hepatocyte. And once all of them lead to the formation of acetaldehyde, this is transferred into the mitochondria, and mitochondria will convert the acetaldehyde into acetate, and that will come into the circulation. So final product of ethanol is acetate, which will come to the circulation from the hepatocytes, and the enzyme which converts the acetaldehyde is the aldehyde dehydrogenase. This is aldehyde dehydrogenase. This is acetaldehyde dehydrogenase. Okay, so these are the enzymes with which the conversion takes place, and this is a very important knowledge that you should have, and sometimes this is asked in the Viva examination also. Now describe the anatomy of the liver. So going back to some basics, you may sometimes get an exam question, theory exam question. Describe the anatomy of the liver. This is the question. What will you answer for this? What is the normal size and weight of the liver in our body? Is the largest gland or smallest gland in the body?
Largest gland in the body.
Largest gland. Liver is the largest gland of the body, weighing 1200 to 1600 grams. It's wedge-shaped and covered by a network of connective tissue called Glissen's capsule. Okay. What else you can write about the anatomy of the liver?
It has
many
two
lobes?
lobes, right and the left lobe.
The next thing you have to describe is how many lobes it has. It has got a right lobe and a left lobe. Which is bigger, which is smaller?
Right is bigger,
Right.
sir. Left is
Right
smaller.
is bigger and left is smaller. Very good. How is it kept in place? Where is its position? Where is it present in the body?
It's present below the diaphragm of the liver from the right hypochondrial area to the
Right
left
to
hypochondrial.
hypochondrial. Very good. So how is it held in that position? Without slipping or falling down, being a huge gland, how is it held in its position?
By the
What are the
ligaments.
structures which are holding it? And where are they attached? So it is connected to the diaphragm and abdominal walls by 5 ligaments. And there are 3 membranous ligaments and 2 fibrous ligaments. And there is one fibrous ligament. Okay. So the membranous ligaments are falciform ligament, which also separates the right and left lobe. Then there is a coronary ligament, that is the right and left triangular ligaments. And the fibrous ligament is the round ligament, which is the embryonic remnant of umbilical vein. So there are totally 5 ligaments which are holding the liver in its place, which is attaching it to the abdominal wall as well as the diaphragm. So this is the knowledge that mostly surgeons should have. We also should know, especially those who are involved in liver transplant, they should have this knowledge without any fail. So this picture shows the various ligaments. Surface anteriorly, this is the falciform ligament, which is separating the right and left, and also it continues down as a round ligament, which is nothing but a vestigial organ. Then the coronary ligaments are the ones which are situated on the top surface, which gets it attached to the diaphragm. Then there is a left triangular ligament and right triangular ligament, and so these are the major ligaments which are keeping the liver in. The lobes are anatomically, the liver is divided into right and left lobe by the falciform ligament. The right lobe has 2 minor lobes, the caudate and the quadrate. Okay, these are so totally morphologically seen from outside. It is 4 lobe. Even though you have 2 major lobes, the right lobe is again divided into caudate and quadrate. Small 2 lobes are there. So this is one classification, morphological classification of the lobes of the liver. Is there any other classification of the lobes of the liver?
Why not our bismuth classification?
Why that? What is that classification called as?
Based on the anatomy of the portal and the hepatic veins, sir.
What is it called as? What is the name for that? It's called segmental lobe classification. Okay, this is called morphological lobe classification. And Cuno, it is to be pronounced as Cuno, not Quinoid. It is a French name, so it has to be pronounced as Quino, which is segmental classification, mainly for the purpose. What is the purpose of that segmental classification? Why
For
should we
segmentectomy of the liver, sir. For the resection of the liver. Without
resection?
affecting.
Yes, exactly. Whenever you want to resect a small portion of the liver, especially for transplanting an adult liver into a pediatric patient, you can just take one small segment so that it can be accommodated easily into baby's abdomen. So the Quino classification is mainly for resection of a small portion without sacrificing the entire liver. Okay. So this is the visceral surface. This is the anterior surface. This is the visceral surface of the liver. And you can see these are the two caudate lobes and the quadrate lobes are here. And the bed for gallbladder, all these things are on the under surface of the liver. Now this is the segmental anatomy of the liver. This is called the Cuno. It has to be pronounced as Quino, which is currently mostly used for the functional liver anatomy. And it is a preferred classification as it divides liver into 8 independent functional units. Okay, so it is this man has found out that based on the compared to the traditional morphological description, he has divided this into 8 independent functional units, which have their own segmental for it has got its own hepatic artery branch, portal vein branch, and biliary branch. So all the three are present in this division. That is why if you take it out and fix it in somebody else, it can function like a normal liver. And the hepatic segments were originally numbered by Roman numerals like this, but now it is in Arabic numerals 1 to 8. That is what is being used. And it is based on the fact that each segment has a dual vascular inflow, biliary drainage, and lymphatic drainage. All these are present in all the 8 segments that we have divided. And this is the picture of how it is divided. It is mainly based on the venous system. So if you can see, this is the main hepatic vein, then there is a right hepatic vein, left hepatic vein. So each vein is draining on an area, and based on that, he has made it one segment here, 2 segment, 3, 4 is divided into 2, 4A and B, and 5, 6, 7, 8. So actually, if you count all that, it should be 9. 1, 2, 3, 4, 5, 6, 7, 8, 9. But for number sake, we say 8 segments, but the 4th segment is a dual segment. It can be divided into 4A and 4B also. You can take part of that. So he has divided this is he has taken the middle hepatic vein, divides the liver into right and left. This plane runs from the inferior vena cava to the gallbladder fossa, and that imaginary line or plane is called the cantilized line. And the right hepatic vein divides the right lobe into anterior and posterior segments, and the left hepatic vein divides the left lobe into medial and lateral portions. So based on the hepatic venous arrangement, the Cuno segments are there, which is mainly for resection of a functional unit of the liver. Okay, so this knowledge is important whenever you think of transplant anesthesia for liver transplantation. Now comes the next important question, physiology question. How is the blood supply to the liver maintained? What are the factors controlling the blood supply? And what is the peculiarity about the blood supply to the liver?
It has dual blood supply from the portal vein and the hepatic artery, sir.
Very good. How much percentage?
70% from portal vein and
25% from the hepatic artery, sir. Totally 25% of the total cardiac output.
Majority from portal vein and a small portion from hepatic artery. Some books say 80-20, some books say 70-30, some books say 75-25, whatever it is. Major portion of blood supply is by portal vein and a small, reasonable portion is by hepatic artery. It's a dual blood supply. Excellent. Very good. Then how is the venous drainage? We
the
already seen this
sinusoids
last slide.
and the sinusoids which drain into the hepatic vein, then into the IVCs.
Very good. So small hepatic venules, all the venules join together to form the right hepatic vein and left hepatic vein from the two lobes, which combine together to form the middle hepatic vein, which ultimately drains into the IVC. Okay, so that is how the venous drainage happens. So liver almost receives about 25 to 30% of cardiac output, which means almost about 1500 ml of blood comes per minute to the liver. It has got a dual supply where portal vein gives about 75% of blood supply and it is 85% saturated with oxygen. Whereas hepatic artery supplies about 25% of the requirement and it is very well saturated to 95%. This is more of an arterial blood supply, and that is why the color difference is there too, for you to remember. Portal vein, which is called, so it is more like a venous blood, but not exactly. What should be the saturation in a true venous blood?
16%, sir.
Saturation.
Saturation.
It is 75%. Okay? Because a normal arterial blood is supposed to have 95 to 100%. Whereas when it returns as venous blood to the heart, it will still have 75% because the oxygen extraction is not 100% at the tissue level. It is only, so that is, the extraction is only 25%. So only in cases of severe ischemia, blood will stay for a longer time and more oxygen will be extracted. And if your venous blood has got only a 60% saturation, it indicates that the tissues are totally ischemic and they are taking more oxygen from the capillary blood that is available. So a decrease in venous oxygen saturation indicates tissue ischemia and more oxygen extraction. In a normal healthy person, the arterial blood should be 95 to 100% saturated and venous blood should have 75% saturation. Whereas here the portal venous blood coming has got more than the 75% because it is coming from, where is it coming from? The portal venous vein. And what is its role? Is it to oxygenate the hepatic cells or some other purpose?
It drains the superior formed by the connection of superior mesenteric vein and the splenic.
It is draining all the food from the nutrients that are carried, digested in the intestinal tract. This tract are transferred to the liver by the portal vein. So the main purpose of portal vein supply is for transferring the nutrients that are there in the intestine to the liver for further metabolism. Okay, so it is mainly a transport function and not for oxygenation. So hepatic artery is the main source of oxygen for hepatocytes, and the oxygen delivery is 50% by both, and 2/3 of the oxygen used by the liver, and the sinusoids, which are the areas where both these blood mix together. So the sinusoids are the vascular channels between the hepatocytes column, which receive mixture of both the hepatic and the portal supply. So here if you see the terminal branches of the hepatic portal vein and hepatic artery empty together and mix as they enter the sinusoids of the liver. The sinusoids are nothing but distensible vascular channels lined with highly fenestrated endothelial cells and bounded by circumferentially by hepatocytes. Why are they so fenestrated or have large gaps? Why these sinusoids are having a highly fenestrated or with a large gap endothelial cells? What do this blood carry? As I told you earlier,
Oxygen.
digested material from the intestine that has got to go to the hepatocytes for its metabolism, isn't it? So to transfer those elements, it has a high fenestration so that all the, whether it is a small molecular weight substance or a large molecular weight substance, it can easily traverse and go to the hepatocytes. Okay, that is the reason. Whereas in the brain tissue, you have the endothelium with tight junctions. You don't want any toxins or any material to unnecessarily go and affect the brain cells. So that is the major difference between the blood supply to the brain and blood supply to the liver. And if you see this picture, see here, this is the portal vein and this is the hepatic artery. Both have a small branch going towards the central vein, which is the drainage system. So the blood flows in this area, as you can see, both of them are mixing here, and this large dilated portion is the sinusoid. And this sinusoid is lined by endothelial cells, which are having a large gaps or fenestrated gaps. Okay, and it is adjacent to the sinusoids or in between the sinusoids are the hepatocytes, and the hepatocytes produce the bile, and this bile is collected and then brought here in the reverse direction to the biliary canaliculi. All these three things combined together, the portal vein, the hepatic artery, and biliary canaliculi, they are called
Portal triad, sir.
portal triad or porta hepatis. Very good. So the blood flow in one direction, the biliary canaliculi in another direction, and ultimately draining into the central vein. The small venules, they combine together to form the hepatic vein, the right, left, and major hepatic veins, and then they combine together to form the middle hepatic vein, which again drains into the IVC. Okay, if you remember this picture, you will never forget the histology of the liver. And in between in the sinusoids, you have this Kupffer cell. What is this Kupffer cells are? What is their function?
Macrophages, sir.
They are nothing but macrophages. And what do they do? They protect the macrophages. Function is to protect from any toxins or bacteria. Okay, these are the policemen of the liver cells. So they will, because liver gets so much of blood supply, any toxin or any viral infection, everything can easily come there. So you need a constant protection in the form of a macrophage, which is called the Kupffer cells. Okay, so these are the, and there is a small space between the sinusoid and the hepatocytes. What is that space called?
Space of busy.
Space of Dissy. Okay, so there is something like a interstitial space through which this nutrients and other things which travels across from the blood to the hepatocyte has to go through. Okay. Now, what are the types of receptors in the portal vein and hepatic artery, and what is its importance? Every vessel has got some adrenergic receptors, isn't it, or parasympathetic receptors. What are the types of receptors present in the portal vein and hepatic artery, and is there any clinical relevance or importance for that?
Sir, portal vein has dopamine receptors, sir. Hepatic artery has alpha and beta receptors, sir.
Okay. Portal vein has only alpha receptor, whereas hepatic artery has got both alpha and beta receptors. Okay. So that's not dopamine receptor, but it is purely alpha receptor oriented. So drugs which can act on alpha receptors can exert their influence on portal vein, but drugs which can act on both alpha and beta receptors, like your adrenaline, will be having effect on hepatic artery. So here, noradrenaline will be more powerful constrictor of portal vein. Adrenaline will be the more powerful constrictor of noradrenaline. But synthetically acting drugs, dopamine, dobutamine, and noradrenaline, all of them have some effect on the vascular tone of these vessels. Now, how is the blood supply to the liver regulated? This is a very common question asked both in the theory exam as well as in practical exam. So, what are the factors controlling the blood flow to the liver?
Intrinsic by extrinsic regulation mechanisms, sir. Hepatic
You can
artery.
classify them into intrinsic and extrinsic. What are the intrinsic factors? What are the extrinsic factors?
Sir, intrinsic factors by the hepatic arterial buffer response, sir.
One, very good. Then
And auto-regulation mechanism also, sir, by the myogenic response.
regulation. Okay, very good. Then
And metabolic control
metabolic
by
response. Okay, very
metabolic
good.
control
These
by.
three are called the intrinsic mechanism: hepatic arterial buffer response, pressure regulation response, third metabolic response. These are the three intrinsic factors. Very good. What are the extrinsic factors?
Extrinsic factors by the neural control and receptor control, sir. Humoral and receptor control.
Humoral. It is called humoral and neural. Very good. Okay, so intrinsic regulation is by hepatic arterial buffer response, pressure flow auto-regulation, metabolic control. Whereas extrinsic regulation can be classified as neural control and humoral control. Now, what about, how do you describe the hepatic arterial buffer response?
Sir, hepatic arterial buffer response, when the portal way, blood flow decreases, the hepatic arterial blood flow increases, sir.
Very good.
It is a reciprocal way of the mechanism, sir.
Reciprocal means, that means when the hepatic artery pressure decreases, portal should increase. Does it have that way?
Yes, sir. Yes, sir. Yes, sir. When the changes in the portal venous system, is there no reciprocal changes in the hepatic arterial blood flow will be there, sir.
So it is a non-reciprocal adjustment. Okay? Don't say reciprocal. Reciprocal naka both when the portal vein flow decreases, hepatic artery should supplement. When the hepatic artery flow decreases, portal vein should supplement. Then it is called reciprocal. நீ எனக்கு செஞ்சா நான் உனக்கு செய்யறேன். Whereas in the liver, it doesn't happen that way. Whenever there is a fall in the portal vein blood flow, hepatic artery dilates and increases its blood flow to compensate for that. The reverse does not happen. So don't use the word reciprocal. It is a non-reciprocal arrangement. And this is very, very important from anesthesia point of view. Why you should be able to say that?
Sir.
Now I will explain that. With an intact hepatic arterial buffer response, changes in portal venous flow cause a reciprocal changes in the hepatic arterial flow. The hepatic arterial buffer response mechanism involves the synthesis and washout of adenosine from periportal regions. That is the major chemical which causes the dilatation and increase in the flow of the hepatic artery. And various disorders which can affect that are endotoxemia, splanchnic hypoperfusion may decrease or even abolish the hepatic arterial blood flow response, which may render liver to more hypoxic injury. Okay, so this is about hepatic arterial buffer response. Please remember that it is one way. Whenever portal flow decreases, hepatic arterial flow will increase. On the contrary, if there is a systemic, because hepatic artery is a systemic vessel. So if there is a systemic hypotension after your spinal, you give a spinal in a patient with liver cirrhosis and the BP suddenly drops, then the hepatic blood flow will hepatic arterial flow will decrease. At the time, portal vein cannot compensate. The patient will suffer from lack of blood supply and hypoxia. Liver will be acutely hypoxic. On the contrary, if there is a decrease in flow due to in the portal vein because of slight hypovolemia, then hepatic artery, if there is an intact sympathetic system, hepatic artery will dilate and increase its flow and compensate for that. So this is what is called arterial buffer. The hepatic artery only buffers a decrease in portal vein. It is not a portal venous buffer system. It is hepatic arterial buffer system. So always remember, hepatic artery is the உடுக்க இழந்தான் கை போல அங்கே உடுக்கன் களையுமாம் நட்பு. ஸோ நட்புக்கு இதுதான் காட்சி. Hepatic artery is the friend. It increases the portal vein, increases the blood flow to the liver. So what about the pressure flow auto-regulation? What is your knowledge on this pressure flow auto-regulation?
Sir, it is a tissue-specific regulator which involves the myogenic response of the vascular smooth muscle, sir.
Both the myogenic of artery as well as vein?
So vascular smooth muscle, sir. Yes, sir. Both artery and vein, sir.
So you mean to say portal vein also has got an auto-regulation?
Sir, only the hepatic artery has auto-regulation.
Then you say both the vessels have got auto-regulation?
Sorry, sir.
That's not the correct answer. So please remember, the hepatic pressure auto-regulation keeps constant blood flow despite the fluctuations in systemic blood pressure. So any organ, kidney has got auto-regulation, brain has got auto-regulation, coronary circulation has got auto-regulation. Like that, nature has made that all our organs in our body should have a predetermined amount of blood supply constantly for their normal function. And whatever be the changes in the blood pressure, it should be maintained, and that is what is called auto-regulation. So in the hepatic, because the liver has got a dual blood supply, both from the hepatic artery and portal vein, it is the hepatic artery which will be able to do the auto-regulation. It is not the portal vein. Portal vein does not have an auto-regulation. Please remember that. Which other systems or vascular supply does not have auto-regulation? Which other such supply or circulation does not have auto-regulation? In the women, after they get married. Telling you the clue. They become pregnant.
Uterus, sir.
Uterus.
Uteroplacental circulation. It is not the uterus. It is the uteroplacental circulation which does not have auto-regulation. Okay. Similar to that, the portal venous circulation in the liver does not have an auto-regulation. Okay. So it is the hepatic artery which has got the auto-regulation, which keeps a constant blood flow despite wide fluctuations in the systemic BP. This mechanism involves what you said as myogenic response of vascular smooth muscle. Okay, this is important because whenever there is a systemic pressure drop, this will take care of that. Okay, and the hepatic artery exhibits pressure flow auto-regulation in metabolically active liver only. That is mostly after a full meal and not in the fasting state. Okay, and it's not likely to be an important mechanism during anesthesia. So you have to maintain that this is because the stomach, we are keeping the patient nil oral. So patient is fasted, and that is the reason why this auto-regulation will not be affected during anesthesia, because the stomach is not having any food in that. So only during postprandial period, this auto-regulation is very, very important. And pressure flow auto-regulation is non-existent in the portal circulation. And the decrease in systemic pressure is often occurring during anesthesia. This will lead to decrease in the portal venous flow. because it is not auto-regulated. So whenever under anesthesia, if there is a drop in blood pressure, it is the portal venous blood flow that will be affected, and that will be compensated to some extent by the hepatic arterial buffer response. Whereas per se, the hepatic arterial flow will not be affected in anesthesia because the stomach is not full, it is empty. Okay, is it clear?
Yes, yes sir.
Okay.
Yes, sir.
Then the third factor of the intrinsic regulation is the metabolic control, decrease in oxygen tension or pH or increase in PCO2 of portal venous blood that leads to increase in the hepatic arterial flow. And postprandial hyperosmolarity also increases hepatic arterial flow and portal venous flow, but not in the fasting state again. The underlying metabolic and respiratory status, hypercapnia, alkalosis, arterial hypoxemia, they also modulate the distribution of blood within the liver. So these three are the intrinsic regulatory factors of blood supply to the liver: hepatic arterial buffer response, pressure flow, auto-regulation in the hepatic artery, and metabolic control. Now, the second factor is about the humoral and neural control. So for that, what is the sympathetic and parasympathetic supply and their effects on the blood supply to the liver? If you see, we talked about neural control as extrinsic factors, regulatory factors. The fibers of which nerves? Vagus, phrenic, and splanchnic nerves. And also the postganglionic sympathetic fibers from T6 to T11 enter the liver at the hilum. And when the sympathetic tone decreases, splanchnic reservoir increases, whereas sympathetic stimulation, which causes vasoconstriction, translocates blood volume from the splanchnic reservoir to the central circulation. Now, if you carefully know this in trauma, when a patient suffers a trauma and lot of bleeding happens, how is the blood volume maintained initially? Because one of the
vasoconstrictions.
So this is
splanchnic vasoconstriction.
Naturally, trauma will cause an increase in sympathetic tone. Tachycardia and hypertension will be maintained initially by the stimulation of catecholamine. So this is the mechanism by which the blood in the sinusoids of the liver, which all can hold up to 500 to 600 ml of blood, will be translocated to the central circulation. So it acts as a blood bank for our body. So whenever there is an increase in sympathetic stimulation, blood from the splanchnic area, which means the intra and the other organs in the abdomen, blood will be translocated from them into the central circulation to maintain the blood volume. Whereas the vagal stimulation alters the tone of the pre-sinusoidal sphincters, and the net effect is redistribution of intrahepatic blood flow without changing the total hepatic blood flow. So sympathetic transfers the blood in the splanchnic circulation to the central circulation, whereas vagal stimulation makes readjustment of the circulation within the splanchnic system. It doesn't transfer the blood to the central pool of the blood, systemic circulation. Okay. Now, what are the hormones which have effect on the blood flow?
Glucagon, angiotensin, vasopressin,
several hormones. So
vasopressin,
glucagon, secretin, bile salts, angiotensin 2, vasopressin, and catecholamine. 1, 2, 3, 4, 5, 6, 7. So 7 hormones as well as cytokines, interleukins, and other inflammatory media have been implicated in the alteration of normal splanchnic and hepatic blood flow. So remember these 7 hormones: gastrin, glucagon, secretin, bile salts, angiotensin 2, vasopressin, catecholamines, and cytokines and interleukins. All these things are the extrinsic control. They play mainly only in cases of emergency and not on a regular basis. The regular basis is the intrinsic factors like hepatic arterial buffer response, pressure autoregulation, and metabolic control. Okay. They enumerate the factors increasing and decreasing the liver blood flow. This is important from clinical point of view. Which are all the clinical conditions or situations which will increase or decrease the liver blood flow?
Hypoxia, acidosis.
That is with regard
will
to
increases the liver blood flows.
There are several things. Okay, so increasing in blood flow can be because of hypercapnia, acute hepatitis, supine posture, food intake. As I said earlier, only postprandial it will increase the blood flow, and drugs like beta agonists, phenobarbital, which are enzyme inducers, all these things cause increase in the blood flow. Factors which are decreasing the blood flow, if you do IPPV, control ventilation and IPPV, you wash out the carbon dioxide, if you cause hypoxia, or pathologically if there is a cirrhosis because the whole thing gets fibrosed and then compresses all the vasculature, then alpha stimulation, beta blocker therapy, halothane and volatile anesthetic agent, and vasopressin. All these things usage will decrease the hepatic blood flow. So these are all points which are important from the clinical angle. So these are all the conditions you should think of if you want to maintain a normal blood flow to the liver. Now the next important thing is the applied histology of the liver. So what are the different lobules described by histology and what is their importance?
Three lobules. Zone 1, zone 2, zone 3.
What are the three lobules? It is
periportal. Zone 1 is periportal, sir, and zone 2 centrilobular, zone 3 pericentral, sir.
Okay, is that the classification of lobules, or is it a part of one description, histology description?
Part, sir.
So what are the other things? Rest of the other parts, part 1, part 2, part 3. Vidya, Risha, Bharati. Okay, I'll show you one picture, and you should never forget the histology and its importance in your life. This is such a beautiful picture that you should remember. There are three important divisions histologically. One is called the classical hepatic lobule. The second is called the portal lobule, and the third is called the portal acinus. Okay, so the classic hepatic lobule is what you are all taught in your primary classes itself. A hexagonal arrangement with 6 sides, and at each corner you have what is called the portal triad, comprising of portal vein, hepatic artery branch, and bile duct. Okay. So this is the classical histological. The purpose of knowing this hepatic lobule, which drains blood from the portal vein, that is from here and hepatic artery towards the central vein. Okay, you can see the diagram where the arrows are pointing. All the blood flow is going from the corners to the central vein. So this is mainly an arrangement which is seen histologically under the microscope, and the purpose of this classic hepatic lobule is to deliver the blood through the sinusoids to the hepatocytes, and finally drain the used up blood through the central hepatic venule. Clear?
Yes, sir.
Very good. Now the second thing is the portal lobule, which is mainly for draining the bile from bile hepatocytes to the bile duct, and that you can see as a triangular shape, which connects the 3 central veins, and you can see the arrows. I showed you in the earlier picture how that bile flow is on the reverse direction of the blood flow. So here the portal lobule is an arrangement which we have done mainly for the drainage of bile from the hepatocytes into the biliary canaliculi, ultimately collecting to become the intrahepatic biliary tree, and then become the right and left hepatic biliary duct, which combines to form the common bile duct, which will then join with the cystic duct to go into the duodenum. Okay, so common hepatic duct which will join the cystic duct to become the common bile duct. Okay, so second portal lobule is mainly for bile drainage. The third thing is the one which is for the metabolic activity, which is called the portal acinus. It supplies oxygenated blood to the hepatocytes. And if you see this, it is a diamond shaped figure where it is for the hepatic artery, which is the main source of oxygen. The cells are divided. The hepatocytes which are close to the hepatic artery, they are called the zone 1 cells. And the ones which are little away from that, they are called zone 2 cells. And the third ones are called zone 3 cells, which are least oxygenated. Okay. So I have formed another questions on this based on that. What are the names by which the zones are called? Already, I think Bala partially told the answer. Zone 1, zone 2, and zone 3. What is the zone 1 cell to be called? What is the name for the zone 2? And what is the name for the zone 3 hepatocytes?
Zone 1, periportal, sir.
Periportal. Very good. Zone 1. Zone 2?
Centrilobular.
Sorry, wrong. Mediolobular. It is a
Medial.
mid zone or mediolobular. And zone 3? That is what is called the centrilobular. Okay, so the zone 1 can be called periportal because it is close to the porta hepatis, and this is the medial portion. So mediolobular, and away from that centrilobular, near the central vein, the cells which are in the near the central vein, they are called centrilobular. And what are the functions? What is the function of these zones? What does zone 1 do? What does zone 2 do? What does zone 3 do?
Sir, zone 1 take parts in urea cycle and ammonia cycle, sir.
Zone 2? Okay. Zone 1 has the highest oxygen supply, and it is important for all the metabolism. Metabolism of fat, metabolism of glucose, metabolism of urea, all these things, everything, all metabolisms take place because of the high oxygen supply. And this is the zone important for protein synthesis. And that is the reason why albumin, which is a part of the protein, is considered as a marker for derangement of liver function. And this is because whenever the liver gets cirrhosis, the oxygen supply will decrease and protein synthesis will go down. And that is why the albumin level is taken as a marker to assess the degree of involvement of the liver function. Okay, so this is the zone 1. Zone 2 receives less oxygen than zone 1, and here it is mainly intermediate enzymatic activity. Okay, it does not involve itself into metabolic activity, but it involves in the enzymatic activity. And zone 3, which has the lowest oxygen supply, but it has the highest number of cytochrome P450 activity, which means all the enzymatic activity like oxidation, reduction, hydroxylation, all the functions, the phase 1 and phase 2 reactions of all the enzymatic activity, they take place in that. That is why if the liver becomes hypoxemic, this is the zone 1 which will be affected first, and that is why all the enzymatic reactions do not take place, and liver, the body starts accumulating all toxins in the body because they are not degraded. Okay, so this picture and these points you should remember. So remember, histologically there is a classic hepatic lobule, the portal lobule, and portal acinus. Hepatic lobule for blood drainage, portal lobule for bile drainage, and portal acinus for all the functional aspects of hepatocytes. Is it clear?
Yes, sir.
Okay.
Yes, sir.
Yes, sir.
enumerate the various functions of the liver and how they happen. This is the next physiology question you should know. What are all the functions of the liver you can think of?
Synthetic functions.
Very good. You can classify them into synthetic function and detoxification function and storage functions. Very good. But the answer I have given it as a group. First one is the blood reservoir, glucose homeostasis, fat metabolism, protein synthesis, drug and hormone metabolism, bilirubin formation and excretion, and antibacterial action. Okay, these are all the physiological functions of the liver. And how does the blood reservoir function take place? 10% of the total blood volume is there in the liver, available for auto transfusion into central circulation, which we saw in the earlier. If there is an increase in sympathetic activity, it will translocate the blood in the liver to the central pool or the systemic circulation. Prevents profound hypotension after minimal blood loss, and it also maintained by neural and humoral control. Now this picture I have taken because there are sphincters which can be dilated or closed to allow the blood to go to the sinusoids. So there are three sphincters, one between the terminal hepatic artery, arteriole and the portal arteriole. This is the first sphincter, arteriolar portal sphincter. Then there is an anterior sinusoid sphincter that is present in the branch of the hepatic arteriole, which is going to join the sinusoid. There is a second sphincter there. And the third sphincter is between the sinusoid and the hepatic venule, which is finally draining into the central circulation. So for blood to accumulate in the sinusoid, these sphincters should relax. For blood to be pushed into the hepatic and to the central circulation, these sphincters should constrict. So the main action is only by the action on these sphincters which can translocate the blood. The second function is glucose homeostasis. So glucose goes to the hepatocytes. As I told you earlier, it is converted into glycogen and kept as a store for release whenever there is a need for hypoglycemia. And it is acted on by the catecholamines, glucagon and insulin. These are the three hormones which are important for the glucose metabolism at the hepatocytes, and it can be also converted into the glucose can be formed from the other substrates. Neoglucogenesis is from lactate, glycerol and amino acids. So this is the main function. To maintain constant blood glucose level is the important function of liver. And the third is lipid metabolism. Sorry. Also synthesis and storage of fatty acids, triglycerides, VLDL, etc. And synthesis of lipoprotein and cholesterol is also done by hepatocytes. And beta oxidation of fatty acids leading to acetyl-CoA and going to the tricyclic carbolic tricyclic acid cycle and ketone body formation induced by glucagon and insulin. All of us know that ketosis is a main important complication of diabetes. So that is done by this mechanism. And ketone body protection important for extra hepatic energy source. So which particular cells in our body use ketone as a fuel for energy? In the absence of glucose, which particular cells in our body are capable of utilizing ketone for production of ATP?
Brain.
Yeah, cerebral cells. They can
Cerebral
use
cells.
ketone in the absence of glucose. Okay, to some extent. After that, they will become depressed. So initially, they can utilize if there is hypoglycemia. Okay. And of course, synthesis of amino acids and deamination, protein metabolism is done, and formation of urea from ammonia is a very important function. And all plasma proteins except gamma globulin and factor 3, 4, and 7, 8 are produced by the liver. albumin daily production is about 1.2 to 1.5 grams per day, and total pool you have a storage of 500 grams. What is the importance of this particular knowledge that there is a total pool of 500 grams of albumin in your body? Supposing a patient develops a decompensated liver function, will the albumin level decrease immediately the very next day?
No,
sir.
How many days it will take to show hypoalbuminemia? It will take 21 days to get a decrease in albumin. Even if a patient develops frank liver failure, it will take 21 days because there is always a storage of 500 grams. Until all this albumin is utilized, patient will maintain a normal albumin level. So even though albumin is considered as a marker for liver damage, the action comes only slowly after 21 days. Okay, so that one, supposing albumin has become grossly low from the normal value of 3.5 to 5.5 grams, it becomes 1 gram, 0.5 gram. That means all the storage has already been utilized and is in the extreme stage of liver failure. Okay. On the contrary, patient has other parameters indicative of liver failure, but the albumin is still normal. That means he is utilizing the storage to maintain the normal value, and he is in the initial stages of liver failure. He has not gone into a total failure. That is the inference that you have to know. And liver disease, there is a decrease in albumin and increase in globulin, which causes what is called the reversal of the ratio. What are the functions of the albumin? It maintains the plasma oncotic pressure, and it mainly helps in binding the drugs to prevent the extra free fraction available. And it also important carrier for many of the hormones and other things. So that these are the functions of albumin. Then the coagulation, which other plasma proteins which are produced are coagulant factors, transport carrier proteins like transferrin, haptoglobin, ceruloplasmin, plasma esterases, complements, CH reactive protein, hormones, protease inhibitors, all these things are synthesized only in the liver. Now, how liver products affect various systems in the body? What are their effects on the cardiovascular system, renal system? Now, cardiovascular effects. Circulating bile salts lead to bradycardia due to decreased effect on the SA node, which we already seen. It also impairs the cardiac contractility and impaired response to beta agonist drugs like your catecholamines and ephedrine. All these things will not act properly in your patients with end-stage liver disease or cirrhosis. And the decreased peripheral vascular resistance also is caused by the effects of the bile salts. Net result, patient will be hypotensive, prone for circulatory collapse. There will be exaggerated hypotensive response to bleeding and more prone to perioperative shock. Therefore, replace volume losses immediately in perioperative period. So this is the inference that you have to remember. So this is the effect of the bile salts and which is produced by the liver. Coming to the effect on renal system, there is a 10% incidence with 70% mortality. This is produced. This is what is called the hepatorenal syndrome. How it is produced? The effect is by bile salts, endotoxins, inflammatory mediators. Decreased cardiac function also leads to hypotension. So GFR also is decreased, and refractoriness of the tubule to antidiuretic hormone. So these and also there is an increased production of atrial natriuretic peptide. So the four causes for decrease in the renal function which cause the hepatorenal syndrome. It is structurally the kidneys are normal. In hepatorenal syndrome, it is a normal structure kidney, but functionally deranged kidney. That is why they say a patient with end-stage liver disease, if you take the kidney from that patient and transplant it to a CKD patient, it will work very well. But because the structure is still maintained. But in the patient with cirrhosis, it will not work because of these reasons. And this results in renal vasoconstriction and hypoperfusion, shunting of blood from cortex, activation of complement system leading to tubular and cortical necrosis. Now the immune system, how it is affected in liver disease, depressed function of the reticuloendothelial system, especially the Kupffer cells which we saw in the liver, they become inactive. And there is impaired T cell production, which is important for native immunity, cellular immunity rather, decreased neutrophilic chemotaxis and defective bacterial phagocytosis. All these things make the patient susceptible to sepsis. So it can be associated with cholangitis or bacteria and absence of bile salts in the intestine. So endotoxins which are destroyed by the bile salts, they enter the portal circulation and start affecting the patient. And coagulation, there can be two methods of exhibition. Can result in either clotting or it can cause in more bleeding also. So the mechanism is decreased synthesis of clotting factors which are produced in the liver can prolong the prothrombin time. So prothrombin time is also considered as one of the important markers of liver damage. So prothrombin and INR and albumin values are considered as two important markers for assessing the severity or the grade of liver dysfunction. So another reason for this is the vitamin K is not absorbed in the absence of proper bile secretion into the liver, especially in obstructive jaundice patients, and the bile is not going into the intestines. Vitamin K absorption is impeded, and that will lead to defective gamma carboxylation of the clotting factors, and to activate them, it will not happen. And endotoxin, hypersplenism, all they lead to destruction of platelets, resulting in thrombocytopenia. And that will endotoxins will also increase fibrinolysis, and so it can produce what is called the low-grade disseminated intravascular coagulation, loss of calcium, and decreased absorption of fat soluble. All this lead to a tendency for bleeding. And endotoxemia, which can be there because of bile salts not going into the intestines properly. So absence of bile in the intestine, increase in intestinal bacterial flora, breakdown of gut mucosa barrier, and translocation of the bacteria will happen. And this will reduce hepatic function and the clearance of endotoxins. So that may lead to endotoxemia. Now, of course, alcohol and metabolism, which we saw in the earlier picture, these are the enzyme involved, and these are the 4 enzymes which I have told you. Another method of classifying the alcohol metabolism is oxidative and non-oxidative. So variations in the genes of the enzymes determine the alcohol consumption and related tissue damage and alcohol dependence. This point is I have mentioned here because you would have seen some people drinking alcohol for a long time without going in for cirrhosis. And some people after 5 or 6 years of alcohol drinking develop cirrhosis very fast. That is mainly because the genetic nature of the enzymes, how they have these enzymes, how they are able to metabolize this without causing a irritation in the hepatocytes or alcohol-induced hepatitis is not present in these people, and that is how they manage to survive without going in for cirrhosis because of the change in the enzymatic activity. So, what is the pathophysiology of alcoholic hepatitis and cirrhosis? How they are caused? So this is the way causes. Alcohol causes increased gut permeability, which lead to endotoxemia, and Cooper cells are inactivated, and tumor necrosis factor, so inflammation. This is how the hepatitis sets in. And the production of acetaldehyde, which is there at the first stage of metabolism of alcohol in the cytosol, as I told you, primary pathway, that also stimulates the production of tumor necrosis factor alpha. And this is also one of the reasons for the hangover effect. For some people who drink heavily, the next day they get a hangover and vomiting. All this is because of the accumulation of excessive acetaldehyde. And this can directly cause hepatocyte injury also. What is the other form of acetaldehyde which we use in preservation of tissues for pathological specimens?
Formaldehyde, sir.
Formaldehyde, formalin. Okay, so these two are toxins. So actually they will be causing direct injury also. The third thing is because the cytochrome P2E1 is also affected, it leads to what is called oxygen stress, and it stimulates what is called stellate cell activation, and that will lead to this growth factors increase, which will cause fibrosis. So from inflammation due to the inactivation of Cooper cells, or hepatocyte injury, which also will lead to inflammation, and stimulation of stellate cells, which causes fibrosis, and nutritional impairment, all lead to state of alcoholic hepatitis. When this goes on again and again, ultimately it can go on to fibrosis. The same thing in a pictorial fashion. This is the hepatocyte, which is affected by all these activated Cooper cells, NK cells, and Cooper cells which are deactivated. All these things result in apoptic hepatocyte, and then these bodies become fibrosed, and it can stimulate the hepatic stellate cells and lead on to fibrosis, or it can just remain as an inflammatory response. It can go in either direction. So this is how the alcohol primed liver cells activate. So this is pathology you should better be aware of. Now, what are the systems involved in liver disorder? Again, we have seen it already in the first slide itself, the chief ranges. So this is another picture to show you. Remember, you can see the derangement that is happening in the liver, and the hematologic derangement, renal, immunologic, cardiovascular, nutritional, pulmonary, neurological, all these things ultimately what they produce in the patient. This picture will be telling you. Now comes the main important thing. How is the risk stratification done, and how is it useful? How do you stratify the risk involved in a patient who is having cirrhosis or DCLD who comes for any surgery or anesthesia?
Child book classification and MEL score, sir.
So these are the various things which are related. You can say that cirrhosis related risk factors, surgery related risk factors, and demographic comorbidities. So for cirrhosis, if the patient is diagnosed as a frank cirrhotic patient, you have the MELD score, you have the CTP scoring, registered Pruckert and Pope score, albumin score, platelet count, ascites, encephalopathy, varices, portal pressure. These are all the things which take into account. And surgery related risk, you can say emergency versus elective, type of surgery, complex nature of the surgery, duration, intraoperative blood transfusion or blood loss that is likely to occur, facility for volume, and complexity management. And demographically, the age, older the age, more risk, female, race, ethnicity, BMI, alcohol use, ASA class, functional status, comorbidities like diabetes or presence of sepsis or cardiovascular, cardiac heart failure, congestive heart failure. All these things are the risk factors. And the models you have are estimate postoperative morbidity and mortality. So with this, the usefulness of this, you can do the patient selection properly, You have to get the informed consent, you must share the decision making, and preoperative risk modification. If you can optimize the patient, you can, if you have the time, you must optimize, and then you must plan for the perioperative management. So this is the importance of risk stratification to get the best outcome so that you can salvage the patient. Now, what investigations are needed in patients with liver disorder?
Complete hemogram, sir.
Complete hemogram, very good. Okay.
Renal function test and liver function test, coagulation profile.
Very good.
ECG, echo, and chest X-rays.
Very good.
Viral markers, sir.
Viral markers, excellent. Okay. So CBC to rule out anemia or infection, excellent. PT-INR, indicator of severity and prognosis. Platelet count and assay and thromboelastography. LFT, albumin, enzymes, and bilirubin. RFT, indicator of volume status and presence of hepatorenal syndrome. Electrolytes can be hyponatremia or hypokalemia, magnesemia. Ultrasound abdomen to find out the ascites, liver, and spleen enlargement. Fibroscan to assess the stage of cirrhosis by texture of liver. EKG and X-ray chest so to rule out alcoholic cardiomyopathy, pleural effusion. Now, how CTP, that is child record 2 scoring done, and how is it used to assess the median survival? What are the factors you take into consideration to assess or calculate the CTP score?
So total bilirubin, albumin, encephalopathy, INR, ascites.
Ascites, very good. So CTP score, you can say bilirubin, P, albumin, ascites, prothrombin time, encephalopathy. So if you take all the first letters, which come the mnemonic BAP, B-A-A-P, BAP. Okay. So earlier it was Bain. Okay. What is that Bain? Instead of ascites, they had nutrition. Okay. So it was albumin, ascites, nutrition, and encephalopathy. So it was called Bain. Then they replace that nutrition with prothrombin time and ascites. Then it is become BAP. So to give points for each one. So when the serum bilirubin level is 2 is grade 1, 2 to 3 grade 2, 0.2, more than 3 you give 0.3. Then similarly albumin decrease, you give the points. In prothrombin time prolongation, you give the points like this. And encephalopathy, if it is present, minimal or advanced, you give that. Ascites also like that, you do the calculation. And it is classified into 3 groups based on the points. A, CTP score A, P, and C. A is 5 to 6 points, P is 7 to 9 points, and C is 10 to 15 points. So if the patient belongs to CTP class A, 1 year survival is 100% after all surgeries, and 2 year survival is 85%. But as the B and C, you can see the mortality and survival decreases to 45. I mean, mortality increases and survival decreases to 45 to 33%. So, what is the reason for developing MELD scoring system and what is its use? Original risk stratification scoring was the CTP scoring. Later on, they changed from that to MELD scoring. What is the reason?
Selection of candidate for transplantation.
Very good. Excellent. Risk assessment tools, MELD score used for mean survival, deciding the priority for liver transplant. Who requires a transplant urgently? If 2 patients are there, the patient with the higher MELD score must decide whether he will need the transplant or one with a lower LD score, depending upon chances of their survival. So the mean MELD score is how is it calculated and what predictions are made using this score? What are the factors taken into consideration for doing the MELD scoring?
Albumin, serum creatinine.
And prothrombin or INR. Okay. So
Yes, sir.
the two things, encephalopathy and ascites, have been taken out because they are more subjective assessments. Okay. One can say, if I am asked to examine a patient, I may say patient in encephalopathy stage 3, and you may say patient is only on stage 2. So it is more subjective. Whereas these lab values, serum creatinine, bilirubin, and INR, they are all objective. Taking this, you have a more solid evidence of what will happen to the patient. And based on the score, you can see that 0 to 9 score, survival 98%, after 12 months 93, after 24 months 90%. Whereas as the score increases to 30 to 39, the survival rate also goes on decreasing. Okay. So the two questions that are commonly asked is why a MELD scoring was introduced, because to assess the priority for liver transplant. The second is what is the prediction is the higher the score, lower the survival, lower the score, higher the mortality, and how it is calculated or scoring system done using the three lab values of bilirubin, INR, and serum creatinine, and not on encephalopathy and ascites. Okay, the subjective assessments are taken away. What other risk scoring tools are used? There are newer risk scoring tools which are available. So it can be ADOPT-LC score, adequate operative treatment for liver cirrhosis, and it can, these are the things that are, this is more of a computerized one, so it will give you the patient how to operate. And there is another thing called ALB score. The albumin bilirubin score grade was originally developed for measure of liver function and hepatocellular carcinoma, calculated based on two objective laboratory values, namely albumin and bilirubin. Even the INR is removed here, and without requirement of the subjective ascites and encephalopathy. And in comparison to MELD score, it relates to the end-stage liver disease patients only. So albumin is sufficiently sensitive to detect the early deterioration of liver function. And it has got CPP, 1 being the best and 3 being the worst. Now, portal hypertension. Am I audible?
Yes, sir.
Okay, it is giving an alarm that my battery in the headphone is low. Okay. Portal, so I will go through quickly. Portal pressure, what is the value?
It is less than 5 millimeters.
It is difference between the portal venous pressure and the hepatic venous pressure. Okay, so the portal vein, which has got a pressure, and the hepatic vein, which is draining the blood, or the inferior vena cava, which is taking the blood away, that difference is called the portal pressure gradient. And normal is 1 to 5 millimeter. How does it manifest at various values? And the value is 5 to 9, it represents subclinical portal hypertension. When the portal pressure gradient increases to more than 10 millimeters, portal hypertension complications are likely to occur in the form of varices, digestive bleeding, ascites, infection, and encephalopathy or renal failure. And how ascites occurs, this picture will show you how the obstruction happens. And there are overflow and underflow theory, which you can all find in the books. And portal hypertension types, I'm rushing through because my headphone may conk anytime. So
Okay, sir.
it is classified in these various groups of what are all the causes. It can be pre-hepatic, intrahepatic, or post-hepatic. And how is the prognosis is assessed based on the gradient. So less than 5 millimeter normal, 5 to 10 mild portal hypertension, and more than 10 significant portal hypertension, 12 very high grade for esophageal variceal bleeding, 22 is high mortality. And this is another part which will be asked in the examination. Patient coming with the gastroesophageal varices and bleeding, how do you manage? Where are all the anastomosis is there? How do you treat esophageal variceal bleeding? This is another question. So we can classify that into first treatment is vasoactive drug, terlipressin, then endoscopy to confirm the location, variceal ligation or sclerotherapy. If the bleeding stops, start the beta blockers and complete the course of variceal ligation. If the bleeding is very torrential, then you use the Tenstaken mute tube or the balloon tamponade. And then further non-torrential bleeding, you can use either ligation or success with the thing. And final treatment is trans-intra-pulmonary shunting. Okay, so this is the final treatment. Hepatic encephalopathy, the causes are, these are the following causes. How is it treated? Another point which you have to know. And hepatorenal syndrome is also known as the functional renal failure. And the treatment, how you do that is mainly by increasing the perfusion. And liver, respiratory problem or hepatopulmonary syndrome and portopulmonary syndrome, portopulmonary hypertension. So in portopulmonary hypertension, you will find there is a severe vasoconstriction in the pulmonary vasculature, which is causing the increase in pressure. Whereas in the hepatopulmonary, there is a dilatation. Actually, the opposite happens, and because the capillary engorgement and angiogenesis happens, the patient has a hypoxia that is happening. The cirrhosis have hyperdynamic circulation, which we have seen already for it happening, and it is also because of the vasodilatation and also hypoalbuminemia. And the other serious pathologies are cardiomyopathy and diastolic dysfunction. Changes in coagulation can be twofold. It can affect the coagulation failure can happen mostly because of the absence of coagulation factors and the increased fibrinolysis. And the anti-hemostatic factors are also decreased, like factor S and factor C. So that may lead to bleeding also sometimes. And how to optimize the patient? You have to take care of the nutrition. You have to correct the hypoglycemia. Hyponatremia is very common, so you may have to treat with aldosterone level. Watch for early signs of encephalopathy. Oxygen saturation in room here to be assessed and proper measures. And paracentesis, if the ascites is very severe, correction of coagulopathy with platelet fibrinogen and based on the TEG value, prevent infection and sepsis, and transjugular intrahepatic systemic shunt. This is something like a dialysis for the kidney that can be done in refractory cases of ascites. And MARS is another new method, molecular absorbent recirculating system, where drugs or toxins dosage are causing this. So what are the goals of anesthetic management? Preserve the hepatic blood flow. Factors decreasing hepatic blood flow are mechanical ventilation, heat, hypercarbia, hypoxia, hypotension, stress of surgery, monitor and maintain renal function, prevent CNS depression, prevent coagulation, preserve electrolyte imbalance. And anesthetic management, induction agent of choice is propofol because it has got extra hepatic elimination and also preserves the hepatic arterial buffer response. Relaxant or saxamitonium and atractorium, analgesic remifentanil or titrated dose of fentanyl, and inhalation agent ISO or CO, and titrated doses of neostigmine. Monitors which can be routine in mild cases and invasive monitoring in severe cases. Regional is safe. There is coagulation profile is okay, and if the diastolic blood pressure is not too low, then you can give and always keep the level below T10. And post-op care, watch for acute liver failure or altered sensorium, increasing jaundice, monitoring renal function, coagulation, avoid infection, paracetamol for block. And so what are all the points that you have to remember in this case are histology of liver, hepatic lobule, portal lobule, postal ulcers, anatomy of lobes of liver and ligaments, control of hepatic blood flow, bilirubin and bile physiology, which I have not discussed, tests for liver function, role of liver in drug metabolism. The types of cases that can be encountered are cirrhosis with portal hypertension patients, obstructive jaundice with the CBD stone, see head of pancreas, and segmental hepatectomy for secondary deposits, end-stage liver disease for liver transplantation, and anesthesia for ERCP are all the things that can be asked. So I will stop here because of already taken time, and also my phone seems to be going down all time. Any questions? Am I audible?
Yes, sir.
Yes, sir.
Okay.
Yes, sir.
So it has been going on, giving me a warning that I may stop anytime battery is too low. So if you have any doubts or any questions, you can either WhatsApp me or keep it for the next class. So we may have to continue some more part in the liver discussion, so which we will have in the next class.
Okay, sir.
Okay,
Yes,
sir.
sir.
Were you all happy with this type of presentation, or if you want me to change that?
Happy, sir.
Okay. Taking too much time to answer that. Thank you. Okay.
Thank you.
Thank you, sir.
Thank you, sir.